Hello, everyone. Good afternoon, good evening, depending on where you're tuning in from. Welcome to the National Ovarian Cancer Coalition's Ask the Experts Facebook Live series, which takes place the last Thursday of each month. My name is Jennifer McClendon, and I am the Education and Programs Senior Manager here at NOCC. And today we're going to be covering a little bit of a hot topic, ovarian cancer and risk. And today we are so honored to have Dr. Carol Long-Roche, a gynecologic oncologist from Memorial Sloan Kettering. It's so great, Dr. Long, to have you on with us today. Thank you so much for joining.
Well, thank you for having me. I always enjoy talking with you and also talking with really anyone who's interested in this important topic.
Absolutely. Thank you so much. We know the topic of risk in regard to ovarian cancer is definitely a hot topic right now, and in some ways has gotten a lot of media attention recently. So we'll be talking through that. And I look really forward to hearing some of that today. But as we know, we still have no effective screening tools for ovarian cancer. But what many don't know is that we might actually be able to reduce our risk, or in some cases prevent our risk of ovarian cancer, which we'll hear more from you about this. So we'll talk about some of the ways risk can be reduced, including some new information that we talked about. And then we'll just go into our conversation here. How does that sound?
Sounds great.
Okay. So just to kind of start us off, can you talk to us about why or how, why is ovarian cancer so hard to diagnose in itself?
Of course. So ovarian cancer is actually a number of different diseases of the reproductive tract. And when we talk about ovarian cancer, we're usually lumping together cancers of the ovary and cancers of the fallopian tube, which when we talk about the ovary and fallopian tube together, we use the word adnexa. And since ovarian cancer is many different types of cancers, we have to be specific with our words when we're talking about risk and screening. But the important thing is that the most common and unfortunately one of the most life-threatening forms of ovarian cancer, we believe now actually starts in the ends of the fallopian tube. And that type of cancer is high-grade serous carcinoma. It accounts for about 70 to 80% of all ovarian cancers. And what we know about high-grade serous carcinoma is that not only is it the most common, but there's no symptoms of this cancer when it's in its early forms, and there's no screening test. And when we made the discovery that this cancer actually starts in the end of the fallopian tube, it all made sense as to why those things were true. The cells kind of scatter out from the end of the fallopian tube into the abdominal cavity. And so, of course, no one feels a scattered cell. And of course, there's no imaging test that can pick that up. Ultrasounds can't even see the fallopian tube. They can only see the ovary. And so by the time a blood test shows an abnormality or we can see anything on imaging, the cancer is quite advanced.
Gosh, yeah, I can imagine, just there's no target to really go in and look at because it could just be scattered. Yeah, that makes total sense.
And there are a lot of people working on kind of new, exciting ways to look for micro fragments of DNA, or maybe even look in other parts like the vagina or the cervix or the uterus to try to find markers, but we're just not there yet.
I was just about to ask you that, Dr. Long, we get the question quite often about, what about these blood tests that we hear about and that they advertise very heavily that say they can pick up early signs of cancer? Does this work for ovarian cancer? And I think you just alluded to that a little bit.
We don't have proof that it works yet. There are a lot of these technologies that are very promising, and many of them might serve to diagnose ovarian cancer, but to find it at a teeny tiny stage or a low stage or a small form where it could be more easily cured, that's the key. There's a big difference between a test that works to screen something to find something when it's more treatable and a diagnostic test. So we're not there yet, but no one wants it more than me, that's for sure.
Okay. Well, that's good to hear. Exactly. So getting into our topic for today, risk and what we can do to reduce our risk, could you speak to us about some of the current options that are available for those that might be at average risk? What can they do to possibly reduce their risk? And then moving on to maybe those that are at higher risk.
So I think, Jennifer, it's very important to differentiate those two groups like you just did, because we know exactly what we should do for patients at high risk. And patients at high risk represent about 20% of all ovarian cancers will occur in someone who could have been identified as high risk. But
Okay.
80% happen in average risk people. And so what are things that we know reduce the risk of ovarian cancer? Well, we know that things like taking the birth control pill for at least a chunk of time, 5 to 10 years, that likely reduces your risk. And there's a lot of theories as to why, but in talking about this most common type of ovarian cancer, it may have to do with the fact that every time an ovulation occurs, it's like a little mini explosion next to the fallopian tube, and that might stimulate some of these cancerous changes. So taking the birth control pill can be risk reducing. Other things, and the thing that's gotten a lot of news recently, is fallopian tube removal. Now, we know that removal of the ovaries and fallopian tubes can be protective in high risk patients, but that has a lot of side effects. And so an average risk person may not want to remove their ovaries and fallopian tubes. So this concept of removal of the fallopian tubes is currently being studied. And we are not telling people to run to their doctors and ask for surgery, because we don't want, as a surgeon, unnecessary surgery is not what we are advocating for. However, there are a lot of opportunities that can be seized to take out the fallopian tubes in someone who's already having surgery. So one of the biggest opportunities is when someone wants surgical sterilization, permanent birth control. So someone who's done with childbearing and is looking for a permanent form of birth control goes to their doctor. Maybe 10 years ago would have said, "Can I get my tubes tied?" Well, now we should remove the tubes. Technically, it's very similar. And so it's just a little modified surgical technique. And we think, and we have good kind of population-based data that will reduce the risk. We don't really know by how much yet, but we think it will. Other opportunities, when someone's having a hysterectomy, if you're having a hysterectomy for, say, fibroids or bleeding, take those tubes out at the same time. And one thing that I'm heavily involved in right now is this amazing project working with other institutions, Sloan Kettering, Johns Hopkins, Dana-Farber, and MD Anderson and MIT, through an organization through Breakthrough Cancer. And we have been tasked with, well, how do we expand this fallopian tube option to more patients, more women and people with fallopian tubes that are having abdominal surgery? Because the question is, well, maybe there's other surgical opportunities where we can take the tubes out. And so that really needs to be studied, because we want to do it safely and equitably. But we think that this kind of concept of, well, if you're already in the abdomen, consider taking the tubes out, might be able to save thousands of lives per year. And that being the most important thing, but a secondary gain is actually billions of healthcare dollars.
And that is so exciting. And again, you were speaking to this about those at average risk, right? That are already scheduling a procedure. So that's
right. And again, we know that sterilization and hysterectomy or GYN surgery, that is a well-established, supported time to consider this and talk to patients about it. And we are actively studying whether there may be other surgical procedures that we could combine this with.
Very great. That's awesome. That's really great. Thank you for explaining that so well. And I tend to use the words risk reduction a lot versus prevention, because I think that gets very confusing in the general population. Yeah, glad you agree, because I've heard some people turn this news into, 100% prevention. And I'm being real careful right now. Okay, great. So risk reduction.
Yeah. So interestingly, even removal of the ovaries and fallopian tubes is not 100% protective.
Yes.
Even that is not 100%. And probably why is that maybe a little cell had escaped from the fallopian tube into the lining of the abdominal cavity before the structure was removed. And the other thing about fallopian tube removal, why it is not 100% protective, is we're only talking about this most common form of ovarian cancer, high-grade serous carcinoma, that we
Right.
believe starts in the tube. There are other more rare types of ovarian cancers that really do start in the ovary. So we don't like to use the word prevention, even though sometimes it rolls off the tongue easily. We
Sure.
do try to use the word risk reducing or protective, in other words.
Yes, got it. While we're talking about this specific news piece, one of the questions I had was, if someone was going to have their tubes removed and who are still wanting to have or what I'm trying to ask, sorry, is
Yeah.
what effect does removal of the tubes have on women who are still wanting families? And what about those who are maybe premenopausal, if their
Um,
question
so the main, and this is it's very important, and I'm always, committed to everyone understanding what each individual part does. The
yeah,
fallopian tube's job is to transport eggs and sperm, and so that they can meet and a pregnancy can form. The fallopian tube doesn't offer any hormones, but it is crucial to the ability to get pregnant without medical intervention, or pregnant through intercourse. Um, and so if someone has their fallopian tubes removed, the only way to become pregnant is through in vitro fertilization, which can be difficult and costly. And so this is not an option for people
yeah,
who want to conceive naturally.
sure.
For some people, they know that they want to use IVF, or they have other reasons. And so in that case, it may be appropriate. It is a very good form of birth control because of that same reason.
Absolutely, absolutely. So what about going along with this as well? What about those who may test negative for, say, a germline mutation, which we know is an inherited mutation? Would they be considered at high risk if they still have a strong family history? And would this be an option for them?
Yeah. These are some of the longest conversations that I actually have in my office, because it's very hard to tease out um, patients who have a normal genetic testing but have a family history. And there's a lot of things to consider. Was the family member who had the cancer, did they have genetic testing? Did they have a mutation? Maybe we don't know. So let's just hypothetically say that there's no mutation in any family member, but there's still ovarian cancer. We do think that that increases the risk maybe up to even 5% over a lifetime. And so these are patients who have really need to sit down with an expert and talk about an individualized risk reducing plan. Is it birth control pills? Is it removal of the fallopian tubes after childbearing is complete? And then maybe removal of the ovaries after menopause? Is it just waiting? There's actually no right answer. This is very individualized, but there are options, and these are people who really should talk to their doctor about
For sure.
a plan.
For sure. Okay, thank you. So we've talked about risk reduction for those at average risk. You mentioned birth control pills. We mentioned this new this procedure, this attention that it's getting. What are some other ways that those at average risk could possibly help reduce their risk for ovarian cancer? Or what would you say?
Yeah, and I just wanted to throw out there that the medical term for removal of the fallopian tubes is called salpingectomy. So you may hear people say bilateral salpingectomy, or risk-reducing salpingectomy, or opportunistic salpingectomy, which is a term that we're not sure we love, but that means taking advantage of an opportunity to remove the tubes. I think for people at average risk, really what we tell people is, one, try to make sure you're at average risk. So talk to your doctor about your family history, and consider genetic testing if there's any question. So that's one thing. Birth control pills, certainly considering this salpingectomy option. Other than that, there is nothing really that we have to tell people. I mean, we always say, generally,
Healthy living,
live
yeah.
a healthy life. We do know that having multiple pregnancies or breastfeeding for a long time might reduce your risk of ovarian cancer, but we don't necessarily advocate that to happen just for that reason.
Sure, sure.
And so, yeah, I mean, I think the biggest thing is to really know your options and have conversations with your doctor.
Yeah, I think that's good. And then those that are considered at high risk, whether they have a family history, a strong family history, an individual history, or have a genetic mutation, having these conversations with their physicians is probably one of the most important things they can do, correct?
Yes. So if there is any question about a family history of ovarian cancer or genetic mutation, or there's a known genetic mutation, it's very important to meet with a genetics counselor. Even if there's not a genetics counselor where you live, one good thing about the pandemic was it opened up a lot of telemedicine opportunities because a genetics counselor will really guide you to the specialist that you need. So we know that there are many genetic mutations that are associated with an increased risk of ovarian cancer, but some of these mutations also have increased risks of other cancers, like breast cancer, and for example, in the setting of something like Lynch syndrome, colon
Yes.
cancer, uterine cancer. And so talking to a genetics counselor about your specific risk will help to guide you to the right specialist. When
Perfect.
we meet these patients with an inherited risk of ovarian cancer, we really take into account some very key pieces of information. So what is the genetic mutation? What is the family history? So some people with a genetic mutation might have family members that were diagnosed at an earlier age or a later age, and that should be considered. And then also, what are that person's desires for fertility or pregnancy? What kind of options might be available to them after they have surgery in terms of hormone replacement? And so all of these things taken together will kind of lay out what we call a pre-vivorship plan.
Oh,
And
I
so
haven't
we
heard
like
that
to,
before.
yeah,
Okay.
we like to call our patients who have had, risk reducing surgery, pre-vivors. It's certainly not the same thing as going through cancer treatment and being a survivor, but it's certainly not always an easy road. And so a pre-vivorship plan will really lay all these things out. Um, Depending on the particular mutation, there are guidelines. The NCCN has very clear guidelines on what is recommended. So for many patients, it is recommended that they have surgical removal of their ovaries and their fallopian tubes. And that, of course, has some pretty serious side effects.
Yeah.
Inability to become pregnant naturally, and inability to retrieve eggs if they wanted to get pregnant with IVF. And then, lack of their own natural hormones or surgical menopause, which can be treated with hormones in some cases, but is a significant change for patients. We are studying, in the same way that I told the story about the fallopian tube being so important, we are studying right now with several major trials that are going on in the United States and in other countries, whether we can start with removal of the fallopian tubes and then either wait until kind of the end of the recommended age range to remove the ovaries, and maybe even wait beyond that, with the hope that one day maybe we won't be recommending tube and ovary removal. We'll just be recommending tube removal. So there's a lot of different, things to consider and work through with
There
your
really is.
doctor.
Yeah, there really is. Yeah. Yeah. Well, that's amazing. I'm excited to hear about all the possibilities that are coming our
Yeah.
way.
Yeah. There's
Well,
the one difficult thing is that the trials that are studying the fallopian tube, and there's two currently, one currently open in the US called the SORAC trial, and then there's another trial in the US called the WISP trial. Phase 1 is complete and phase 2 should be open soon. And these are the trials looking at, removing the fallopian tube and removing the ovaries later. The hard thing is it's going to take a really long time before we have results, because we have to do this enough, and then we have to hopefully watch people get old and not get cancer, and then we'll know that it's protective, but that takes a long time.
Yes, absolutely. Well, thank you for that. We have some questions that are coming in through our chat. I'm going to take a quick
Okay.
look here. But one of the ones that we did have that came through, let me see here. I think you already answered this one. How would the removal of my fallopian tubes affect my fertility? I think you've already kind of addressed that, but if you
So
want to,
yeah, just to re-clarify, because this is a
yeah,
very important
okay,
concept. Removal of the fallopian tubes would make it impossible to get pregnant naturally. Someone would
okay,
have to have IVF to get pregnant. Now, if they had IVF and were able to become pregnant, the pregnancy can proceed as normal and the fallopian tubes won't impair that, but that IVF would be a key step.
got it, got it. Um, let's see here. I've heard that some women who have, okay, I've heard that some women who have tubes removed still stay on birth control pills to make menstrual cycles manageable. But do you still have a menstrual cycle if you have no tubes? Meaning, no egg delivery to
Yeah.
uterus. I'm not sure. That's a good question.
Yeah, no, that's a great question. Yes, everything else works exactly the same if the tubes have been removed. So the
Okay.
ovaries still secrete all the hormones, and the
Yep.
lining of the uterus, which is called the endometrium, still goes through its, cyclic changes related to those hormones that come from the ovary. And so people still have menstrual cycles, even when the tubes are removed.
Got it.
The choice of taking the birth control pill is a very empowering one to some women. They really like being on the pill. It sometimes can make the menstrual cycles very light and manageable, and sometimes people can even make them go away. And so there are definitely people who still stay on the pill for quality of life purposes or kind of secondary benefits beyond just contraception.
Okay. Great. I'm looking at the questions coming through, and one of them is a little off topic, but it kind of is related to this, if you wouldn't mind. So someone is asking if you had your fallopian tubes removed. This is a hot topic, as we can tell.
It's a
If
hot
you did
topic.
have, yeah, if you did have them removed, whether this would also reduce the risk of peritoneal cancer. So
Oh,
I don't
that's
know that,
such a good question. That's such a good question.
yeah, and you
So,
might talk about how ovarian cancer encompasses, yeah.
yeah. So even 10 years ago, we used to tell people with this high grade serous ovarian cancer, we used to say some people had high grade serous ovarian cancer, and some people had high grade serous fallopian tube cancer, and other people had something called high grade serous peritoneal cancer. We used to divide them into these different buckets. But now we understand the process better and we realize that it's all the same thing. And so
Mm.
preventing, there, it just rolled off my tongue, reducing the risk of high grade serous carcinoma would reduce the risk of all of those things because
Oh, okay.
they all come from the end of the fallopian tube. Now,
Oh, really?
one because it's all the same high grade serous carcinoma. Now, there are some other types of rare peritoneal cancers that are not GYN in origin, but because, you know, I mentioned before that even removal of the ovaries and fallopian tubes together doesn't entirely eliminate the risk. And the thinking is that maybe there was a little abnormality in the fallopian tube that kind of fell out into the peritoneal lining of the abdominal cavity before the structure was removed. That patient we would still call having peritoneal cancer because their ovaries and tubes are out, but it's still all the same origin. So to answer that question, if we're talking about high-grade serous carcinoma, which is the most common type of ovarian cancer, then yes, we do believe that removal of the fallopian tubes will reduce that risk. There's going to be some time and studying needed to be able to tell people by how much, but
Okay. Well, that's interesting. Did not know
yeah,
that.
it's a great question.
That is a good question. Yeah. Um, we have about 5 minutes left. Man, time goes fast, doesn't it? But we do have another question here that I think is try to keep it generic here and not too personal. But someone has a mother who is 81, just diagnosed, had genetic testing, didn't have any genetic mutations. And this person is 60, in their 60s, have not had any children, had their period at an early age, early menopause. And she's considering, does ovary or fallopian tube surgery make sense for someone in this particular situation? So just that just so complex, right? The questions and discussions that you can have with your physician. Yeah.
Yeah. And this is a common scenario, and I'm very, very sorry that person's mother is going through that and that she's going through it. But we do think that a family history, especially a family history in a close relative, may increase someone's risk. So that person, may, with all the tools we have at this moment, which are imperfect, we would say that person may have an increased risk of getting, ovarian cancer or fallopian tube cancer in the future. Whether or not to do surgery is something that definitely needs to be talked about with a person's doctor, and all sorts of things come into play. How risk averse someone is, right? If we said 5% risk, someone may say, well, if it's 95% chance that I'm not going to get cancer, I don't want to have surgery, and that's fine. Other people may say, sign me up. But then other things like, other medical conditions, prior surgical procedures that person has had, all of these change the risks of surgery. Most of these surgeries, tube and ovary removal or tube removal, can be done with tiny incisions laparoscopically. And it's usually a fairly straightforward recovery, but surgery can be serious. So and that's why I kind of started this all by saying we are not telling people to run out and request surgery, but we want people to kind of get on board with our mission of studying how we can, at least have this offered to more people. But yeah, I would say that person could absolutely talk to their doctor about a surgical risk reduction procedure, and so that they could weigh the risks and benefits in their own personal situation.
Sure. Yeah. Well, thank you. Thank you for that. One other one, if you wouldn't mind. I know that we're talking generally here about risk of developing ovarian cancer. And if I may ask this question that came through, for someone who's been diagnosed with ovarian cancer, and I want to ask it because we've gotten 3 or 4 of the same question, is there anything that those who are, possibly, at risk for having a recurrence, anything that they should be doing or that they can do to lower their risk of a recurrence, if you don't mind if I ask that?
No, I don't. This is also very individualized. And so one of, and just to tie it all together, genetics are very important. So, there are several different types of maintenance therapies that people can receive after their treatment is complete. So their, surgery and chemotherapy is complete. And then there are these options for maintenance drugs, which can, prolong remission, or keep someone in remission, hopefully forever. One of them is called a PARP inhibitor. And this works the best in patients who have a genetic mutation, like a BRCA mutation, but not necessarily limited to that. And that mutation could be in their bloodstream, inherited from a parent, or it could be in the cancer itself. There can also be other features of the cancer. The abbreviation is HRD, whether the tumor is HRD proficient or deficient. And all of those things might let us know that a PARP inhibitor could work for maintenance. Another drug that is commonly used is called bevacizumab, and it's an infused drug that can be used as maintenance therapy. Beyond those 2 things, we're left with not a whole lot of kind of science-based options, but many patients will just try to focus on, healthy living, whatever that means for anyone, and diet, exercise, meditation, prayer, whatever constitutes healthy living for someone. But of course, the science has focused on the drugs.
Sure.
So that's where we have the data.
Yes, absolutely. Okay. Well, it is that time. I want to thank you so much, Dr. Long, for your valuable insights on somewhat a confusing but very important topic. It's so exciting to learn more about the advances that we're making in ovarian cancer for sure. Thank you so much for
You're
your
welcome.
work that you're doing in this area. Very, very important. Thank you so much. And with that, we thank you again for participating. And if you guys have any other questions, please let us know. We also have some really great information on our website at ovarian.org about ovarian cancer risk and questions that you might want to ask your doctor. So take a look at those. And with that, we will talk to you next time. Thank you so much, Dr. Long. We really appreciate it.
My pleasure. Take care.